Okay, here we are. Chapter 33. We have 84 slides. Okay, so I have a timer going. Anorexia, nausea and vomiting. Describe therapeutic measures and nursing care for anorexia and nausea. Anorexia due to disease process. So this is inability or lack of interest in eating, inability to eat anything. This can be from cancer, chemotherapy, all cause nausea and vomiting, as well as do a number of other diseases. And so we need to find a way to keep some type of homeostasis, electrolyte balance, while our patient is going through this type of problem with nausea and vomiting. Nursing care plan nursing care for a patient with acute chronic gastritis. Okay, that's pretty common, the gastritis, so we want to make sure that we look into that. This is, let's see, list current pharmacological treatment for peptic ulcers. Okay, pathophysiology, lack of appetite, common symptoms. So with many diseases, so we want to monitor their input and output, their vital signs, electrolytes. You guys know all this stuff. Okay, nausea and vomiting. Therapeutic interventions, protect their airway from aspiration, medications that we can give them. Make sure you're aware of what types of medications that can be given for nausea and vomiting. We have NG2, we can keep them hydrated that way. And then clear liquids, if it's PO, clear liquids and dry toast. You can use nausea and risk for aspiration for your nursing diagnosis. Okay, obesity. This is on page 639, that 638, and goes over to from there on. This is familiar. You need to be familiar. You already are, but refamiliarize yourself with the figure 33.1, which is a BMI chart. This is self-explanatory. It's there. That is an illustration of the body mass index, the BMI. So refamiliarize with that. Caloric excuse. Okay, so this is if you're taking in, caloric intake exceeds your energy expenditure. If you have, that means you're not putting enough energy out and versus the calorie intake that you have. What are the comorbidities of this? Well, there's lots. Gallbladder disease, heart disease, since that is the number one killer in our country. I would say you should absolutely know that that is high on the list. Hypertension, of course, sleep apnea, diabetes, and depression. We know that. We call that like the trifecta, right? It's heart disease, hypertension, and diabetes. How many patients have you seen with these three comorbidities? So they kind of all go hand in hand, and depression, of course. Therapeutic intervention. So what types of weight loss can we do? I talked to you guys a lot about meeting patients where they're at. What's something that's going to work for them? A meal plan. You can have the best meal plan. It has to be something that is going to be work in their life. So very important that you not judgmentally find out where they're at with what they are currently doing. So a healthy, balanced diet is what the goal where you eventually want to get to, but that takes time. So there are surgical managements, bariatric surgeries, and that begins on page 639 as well under bariatric surgery. They have a BMI over 35 with severe health effects. There's a lot involved in that. Make sure that you are familiar with that. Figure 33.2, there are the different illustrations of, I think that we're going to come up on a slide with that shows the different types of bariatric surgeries. Yes, you do need to be familiar with that. So look at those. There they are. That's the illustration I was talking about. All different types. They are, of course, extremely invasive way to lose weight because there can be lots and lots of problems. So you're not doing this type of discussing this type of option unless your weight is life threatening and you have explored all other options. So, some complications: vomiting, erosion of the gastric tissue, breakdown of staple line, leaking of stomach secretions, infection, and or death. Absolutely happens. It's not very uncommon, right? So make sure that you familiarize yourself with that. Post-op care, clear liquids, progress. Okay, this is something that you can look at yourself. Post-operatively, I'm sorry, always infection. That's going to be your number one thing you want to look for: infection, signs and symptoms of infection. Their oral health, yes, that is important. Prevents pneumonia. Want to cut down on bacteria. Antibiotic prophylaxis. There's quite a bit of maintenance that has to happen after. Conditions. Okay, these are different things that are on your oral health that are going to be included. Yeah. Inflammatory disorders. These can be triggered from any of these things here. Oral cancers. They can occur anywhere in the mouth. You can see quite a bit of baseball players that have used chew. They're just a frequent population to have, or popular population to have oral cancers because they do that, but there's all different, types of people. Anyone that is putting chew, tobacco, cigarette smoking, any of those types of things, alcohol absolutely increases that. But they'll get cancer of their jaw, cancer of their throat, of their mouth, their lip, anywhere you can get, or in all of those places. So, and lose parts of those areas where half their face is gone. So, signs and symptoms: painless, difficulty in chewing, swallowing, and speaking, biopsies. So, you can see here, there's an illustration. It's pretty extensive. There's nursing care. Okay, let's see. Signs and symptoms. This is esophageal cancer, which is very serious. Often, it can, for a lot of different reasons, but what we'll see first is difficulty in swallowing, a feeling of fullness. That is not uncommon with cancer. Pain in chest, foul breath, food regurgitation. Your esophagus, which is, right, it's this long tube in so again, look at that diagram, go back. You can see and how greatly would that affect. Look at all the different things. So it's food, it's our passageway, it's the freeway, right, where food passes along. We have gastric juices and everything coming up along that way. So there's a lot of, that's why those signs and symptoms make sense. Okay, we can do barium swallow tests. You do need to know what type of diagnostic tests are relevant here for esophageal cancers. They're going to do biopsies, endoscopies, all these different things. What can we do? Radiation, chemo, and surgery. Like most all cancers, how advanced is it? Early detection is always the best. But what options you have, if they're able to do surgery, they will. If they have to do surgery first, then chemo, radiation, all different kinds of combinations can happen. Nursing care. So we want them to stop, obviously, any alcohol or tobacco intake. Postoperatively, make sure we maintain an open airway, pain management, swallowing, and nutrition. Their swallowing mechanism is greatly affected and inhibited, so you're gonna have to find another way for them to eat, possibly. So they might have a G tube temporarily. Hiatal hernia. Okay. Hiatal hernias are lower esophagus, stomach slides up through the hiatus of the diaphragm into the thorax. So you guys know what hernias are, right? It's a protrusion. So these are just different areas. So we have a diagram there of the different types of, this is normal, sliding, rolling. So look at those. Where we see them most in smokers, those over 50, obese, pregnancies, GERD secondary. So a lot of people, how many people do you give that have GERD do you give medications to in the hospital that you've seen lots, right? So make sure that you are looking into that. I'm on page 644, 645, around there. Hiatal hernias. Okay, let's see. Let's keep on going. Usually, you don't have signs and symptoms, pain, heartburn, fullness, reflux, or those are, it can be any combination of those. That's how they diagnose it with the x-ray or fluoroscopy. What do we give? Antacids, small, frequent meals, no reclining, 1 hour after eating, raise your head. They often feel more comfortable sleeping in like a recliner chair. They can't lay all the way down flat. It feels like almost like you're having a heart attack because it can be burning so much. You want to not eat spicy foods, alcohol, caffeine, smoking, all irritants. Eating 3 hours before bedtime is preferable. What do we do for surgical management? The doctor will perform a correction there. You can see a fundoplication. Nursing care, we want to do teaching preoperative and postoperatively. So monitoring dysphagia with eating, report any dysphagia, and repair may be too tight. This is again another very invasive surgery. There can be complications, so it's serious. Patho, gastric secretions, reflux into, this is for GERD. Lower esophageal sphincter is not closing tightly, so it's opening and allowing acid to rise where you're going to feel like you can taste vomit. They burp a lot. It causes pain and pressure in the chest. Our feeling of pressure, that is from the acid. So heartburn, regurgitate sour, that's what I just talked to you about. How do we diagnose these? A barium swallow test will show that. So they have you swallow this barium, and then they're able to see it on the screen exactly what is not working properly and see if they can repair it. They can monitor your pH as well. Respiratory complications from GERD. Yes, asthma, aspiration, pneumonia, right? If all this acid is continually coming up, right, this makes sense of how these problems can happen. Furthermore problems. GERD can change. So Barrett's esophagus. This is on page 645. So review that. Lifestyle changes. My exercise, even just walking, is a very helpful thing to do. Antacids, histamine. You see PPIs given. You guys know about these or should be familiar. We've given lots of these. Okay, those are what we can do. Diagnosis, acute pain, education. Lose weight, that is definitely going to be an aid in relieving some of the GERD symptoms. If you have weight loss, then it's easier on your body. Just the physiology makes sense that it's going to relieve some of the pressure and not be pushing it up so much. Low fat, high protein. Avoid caffeine, dairy products, especially spicy foods. Mallory-Weiss tear. Okay, these are here. Tells you all about that, and I believe you can see that on page 646. I'm sorry, I'm running out of time. Okay, yep. And signs and symptoms: bright red, bloody emesis, bloody or tarry stools. That's what we look at. Okay. All the same things: avoiding alcohol, smoking. Esophageal varices. Okay, this can happen from alcoholism quite commonly. Dilated blood vessels in the esophagus. Ruptures can be life-threatening, yes. See page 35 or chapter 35. So that's going a little bit forward. Inflammation of stomach, abdominal pain, remove irritant substance and acids. This is for gastritis, common gastritis. Okay, so it can be acute or chronic, and it can be extremely painful. Um, Pathoprotective mucosal barrier is broken down, autodigestion. If it's severe, you can have perforation and scarring. Signs and symptoms: abdominal pain, nausea and vomiting, anorexia. We see abdominal tenderness, feelings of fullness, reflux, and belching or burping. So this is from just what we have, our common gastritis. A lot of people can have this. Again, it can be um, mild to moderate to severe. Um, what do we do? Treat the cause. So you want to probably make a change in your diet. You want to lose weight. You want to do some exercise. Avoid alcohol. Avoid all the irritants, right? So smoking, alcohol, spicy foods. Take your antiemetics, antacids. This is stuff you guys know. Chronic gastritis type, autoimmune gastritis. Okay, this patho. It can be from an infection from H. pylori in the lower stomach. Signs and symptoms. Treatments. Antibiotics is definitely going to be introduced here. Stress-induced gastritis. Can you have stress-induced gastritis? Obviously, because there's a slide for it here. It's in your book. So this is when people are like, they can feel it, and this can be stress that you are aware of or just ongoing stress. Ischemia, damaging mucus barrier. Acid secretions create ulceration. So you can feel that. Like it's like, oh my God, I feel like a burning hole in my stomach. That can be an ulcer. That can be exacerbated by stress if you already have. And if you have those other risk factors, like you're obese, you eat poorly, you drink and smoke, those types of things, and then you have a lot of stress, right? That's why they tell you, then it can affect you physiologically. So, what can we do? Quick trauma care, early feeding, prophylactic antacids, histamine blockers. These are the things that are going to help. Binders to ulcer base. Peptic ulcer disease. It's an erosion of the GI lining. It is curable. The cause generally is H. pylori again, and it will be exacerbated with smoking and NSAID use or increased with it. Okay. Gastric. Your high left epigastric, abdominal burning, gnawing pain, increased 1 to 2 hours after meal. Duodenal. This is the mid epigastric, so this is a different area, peptic ulcer. Look at all of those things. What are my signs and symptoms, my complications? Again, start and stop this slide where you need to so you can review this. What are my peptic ulcer diseases? Diagnostic tests down here. Okay, treatments, same. Nursing diagnosis, okay, this is what you can pick. Gastric bleeding from ulcer perforation. Okay, therapeutic interventions, nothing by mouth, NPO. So we want to make sure if you're having gastric bleeding, there's going to be NG tube, oxygen, nursing deficit. Okay, nursing diagnosis is deficit fluid volume. Malignant cancers, malignant lesions in stomach, men greater than women. H. pylori infection, risk factors, poor prognosis. Okay, signs and symptoms. We have here serum gastrin. Okay. Therapeutic interventions. We can have a subtotal gastrectomy, so that will remove actual part of your stomach, or a complete removal of the stomach. Okay, these are just different areas, different types of surgeries. This is showing an illustration of what they remove. Acute pain, fear. They're going to remove your entire stomach. Yeah, I would be fearful. Okay, nursing care. What can we do here? Look for signs and symptoms of infection, pain control, complication, hemorrhage, gastric distension, dumping syndrome. Absolutely. That's it. Okay, I'm over my time.